Thank you. It's good to be here. I'm a child and adolescent psychiatrist, so it's quite daunting talking to a group of adult psychiatrists. We come from a common background, but I think we do diverge in the kind of services that we work within. And my work in psychiatry has been quite interesting. I think my first job in psychiatry and general adult psychiatry was in Barnet in North London, and I worked with Lawrence Ratner, and the standard approach to first assessment of a crisis presentation of an adult in the community was to go out in a team with a social worker who was usually trained in family therapy, and with a CPN, and with someone like me, a junior psychiatrist. And I thought that was normal. I thought that that was the way we understood the context of mental health in the community. And then I went in to train in child and adolescent psychiatry, and I worked in London and then out in Amersham. And I was working out today on the way here. It's probably 20 years since I saw my first child with ADHD. So back then there were new treatments, long-acting forms of methylphenidate just coming out, and but it was kind of at the beginning of a growth in thinking about childhood ADHD and recognising it. And then I moved out to Wiltshire and started getting interested in young people with complex presentations, and I was part of developing a young people's substance misuse treatment service in Wiltshire. And there weren't actually lots of psychiatrists working for AWP who were made redundant in 2009. It was only me. But that was a big wake-up call to what was going on in the world of psychiatry. That was a substantive part-time post, but I also had another substantive part-time post, and that's I still continue in that work. I work 7 sessions in Bristol with a young people's substance misuse treatment service there. Now, you may be wondering, where then does ADHD fit in? Well, in terms of overlap and comorbidity, the overlap in children and adolescents with substance misuse and ADHD is highly significant, and with offending behaviour, and with school failure. And so to be in a service that works with adolescents who are at the margins of society and who've usually dropped out of education and often had unrecognised mental health disorders and often had ADHD which is unrecognised. That's where I've developed this real interest with the complexity of adolescents and ADHD presentations in adolescents. So that makes transition enormously complicated. Anyone know what this is? A manhole cover, yes, a circular manhole cover. Why are most manhole covers circular?
So you can get down without hurting yourself.
That's a good one, yeah. Slightly lateral thinking, very good. Any other ideas? What happens to a non-circular manhole cover if it tips on its side? It falls in. Yeah, exactly. Okay. What happens to young people in transition? They are not the right shape. They fall through services, all sorts of services. Our service, it's a specialist service with substance misuse. We work intensively with young people. It's an assertive outreach model. We have about 60 young people on our caseload with a multidisciplinary team. Now that's a small number, but it's intensive work, about 180 referrals a year. How many of our young people transition into any sort of adult mental health service, would you guess, in a year?
Well, shouldn't the question be how many are actually suitable and how many actually get it, isn't it? Isn't that the question?
Okay.
Because I mean, I guess a lot of them are suitable, but they don't get it.
They don't get the service?
Yeah, that's I would guess.
Yeah. So we successfully transition 1 or 2 young people a year into adult services. We have, they are the wrong shape entirely. We work in the NHS, we work in linear models, care pathways that make assumptions that life, particularly in adolescence, is without complication. And our experience and the experience of young people in our service, and I'll be talking more about them, is that they don't transition very easily at all. But I do have solutions to that. I don't want to be very negative or critical. You know, I think we can, as a body of clinicians, change the services and work in different ways that will allow for these transitions. So this is simple, isn't it? Very straightforward in adolescence. Any of you have teenagers at home? I have 2. Okay, makes it all sound terribly straightforward. Growing up to develop skills, develop independence, autonomy, confidence, work well in relationships, feel confident with your peer group, with friends, with managing self-control, with going out and drinking and coming home safely. Resilience, building up problem solving and skills of how to maintain your confidence when you're getting knocked back at school with exam results. First sexual encounters and relationships. Negotiation and conflict resolution. We don't see these sort of stormy seas and these tantrums and have concerns about our children going off and not coming home when we're expecting them. It's all straightforward, isn't it? So if you have ADHD, life is very much more complicated in adolescence. So what does NICE say about the aims for transition services? Well, we want to decrease the number of young people who disengage from services. We want to reduce the distress from symptoms of ADHD in young people and in adults and their parents or carers. Kind of suggests that we might work with families, doesn't it? Work with parents alongside young adults, possibly. Improving clinical and social care outcomes, reducing inequalities, increasing patient choice. This is what NICE say. Is this what's happening? Is this the kind of services that are growing? So the NICE transition for young people is for young people with significant symptoms of ADHD. So we presume that they should have already had a diagnosis. And a transition to include the treatment of coexisting conditions that require treatment. Does that involve substance misuse treatment? When we talk about transfer of young people into adult services? Well, you get a very mixed response. Things have changed in the last couple of years in Bristol. But initially, when we were trying to transfer young people into the adult ADHD clinic, they wouldn't be seen if they had a coexisting substance misuse problem. And they were being asked to go to get into the adult drug treatment service, but they didn't meet the threshold for that service. Or into for GP care, perhaps, of their substance misuse. And this is, talking about problematic Cannabis and alcohol misuse. This is not necessarily talking about opiate dependence. But if you are talking about opiate dependence, usually the door is very firmly blocked. So planning in advance, so when does that mean? Does that mean at 15 and a half do you start planning it? Or do you wait until 17 and a half or 17 and 3/4? What does that mean? An assessment at school leaving age. Well, that's great if they're in school. What if they, part of their difficulties has been the complexity, the marginalisation, dropping out of school. If they're not in school, and this is where a significant proportion of young people with complex mental health conditions are going to be, they're not going to be in school. And flexibility about the timing of that transition. So this is what we're aiming for. So just to take us back to adolescence and think about adolescence and whether at that stage we're on a journey that we know where we're going to end up. This is an adolescent, his story. So he was saying that he'd learned not to care. He was smoking a lot and using cannabis, pot, and drinking. He came from a family where there were alcohol problems in his family. He would use cocaine if he had enough money. But not smack, so not heroin, because he saw what happened to Mickey. So any guesses as to who this rather famous person might be?
Brand.
Sorry?
Brand.
Brand, Russell Brand?
Yes.
No.
David Cameron, yeah.
David Cameron, not David Cameron. Okay, it's the president. It's the president of the United States. So we do, in reality, make a lot of assumptions about young people, particularly if they're misusing substances or their lives are chaotic, or they've got family difficulties, or they're not doing well in school. But we don't know where they're going to go and where they will end up. And I think our jobs as psychiatrists are about to help them as much as we can get onto the right track. And it's about shifting with that complexity and being very flexible. And I think trying not to be too linear in our thinking, trying not to compartmentalize them into boxes of having this or that disorder. So this is a study in 2009 carried out by McCarthy, and this is the what happens to prescribing in the UK through adolescence for ADHD treatment. So the black line at the top is the predicted number of people, the decreased number of prescriptions that would occur as symptoms are ameliorated, or as an expected reduction in the number of young people in treatment through adolescence. And you can see that actually the drop-off in young people in treatment goes off significantly underneath that line. So in this study, at 21, there were no individuals who had continued in treatment into beyond the age of 21. So to me, that says we should be really, really interested in children's services, in thinking about how we adapt and develop our services to keep these young people in treatment. But we may have to reorganise those services in order to do that, because they may not be in school and they may not come from families who are supporting them getting to appointments. And we should be really interested in all those who drop out, because where are they going to come back into adult services? So, in talking about a couple of clinical case scenarios, I want to give you some examples of the common issues that we're thinking about in adolescence. This is apologies to the actress in Juno. That's the photograph of the lovely film Juno. Patricia Quinn, who is probably the world authority on ADHD in girls, makes the point that there is no genetic and sex chromosome link that would really give the basis of ADHD being more prevalent in boys. ADHD is the disorder which was first described in boys, and her argument is that actually if you look at the symptom constellation of ADHD, and there's quite a spectrum, it just looks different in girls, and it's often more complex. But for both boys and girls with ADHD, there's a much higher likelihood that they will start having sex at an earlier age, not use contraception, take risks with their sexual health, be impulsive in relationships, and girls tend to be more compliant. They want to please people, they want to do the right thing, because their experience of having ADHD is to lose confidence and lose self-esteem. So you get into areas that you may not think about. This is the kind of stuff that our service works with in Bristol, about sexual health, young parents, substance misuse and their treatment, housing difficulties, the social isolation and stigma that comes in being a young person who's not in educational training and has mental health difficulties, often have complex family relationships, often turbulent, financial difficulties, and perhaps other mental health difficulties, particularly depression and anxiety problems. So I'm going to talk to you about this young woman, a successful recent transition to Dr. Badat's service. She had a childhood history of ADHD which was undiagnosed. She was a bright, fidgety, sociable, talkative 15-year-old who was constantly being told off in class. She was easily distracted, but she wasn't awkward, she didn't misbehave. If she was distracted and not following what was going on in class, she would apologize and feel that she was thick and try and get out of the class as quickly as she could. And then she stopped attending because she was constantly being told that she was a failure, and she felt a failure. And when she stopped attending, she got into substance misuse problems because she was then involved in an out-of-school peer group where the risks significantly increased for other problems. She had a history of cocaine dependence. That came first, after some use of amphetamines. And she later developed opiate dependence. So she was 17 and in treatment for ADHD in our service, and very stable in treatment for opiate dependence. She was on a dose of buprenorphine, 16 milligrams, and she was doing a very slow reduction of that alongside her ADHD medication. And then she became pregnant. So we worked with her, and she decided that she wanted to stop her ADHD medication through the pregnancy. And she did very well, delivered a baby, and a healthy baby boy. And then she was 18 and due to transition into adult services. And it took us 2 years to transition her, basically. The priority was to keep things stable, and we tried to transition her to the perinatal mental health service, but her psychiatric disorder wasn't severe enough, and she was coming off her opiate treatment, So she was also seen as a substance misuser, so she couldn't get to that service. Couldn't get to the BSDAS, the Adult Drug Treatment Service, because she was too well. She would be in the category of GP and shared care arrangements. She didn't at that time meet the criteria for the ADHD clinic, so she couldn't go there, but also she wouldn't, within that clinic, have anything else around her. So we continued to work with her, and she stayed in our service, and we continued to tell our commissioners, who were very unhappy as to why we were seeing someone over the age of 19. We are actually commissioned up to the age of 19th birthday, which is unusual for child and adolescent services, but it certainly helps. And 2 months ago, she had her first appointment in the ADHD clinic, and she's continued in medication. And I think she suggested it might be helpful if the clinic had a creche or somewhere that she could safely go with her baby. You writing that down?
Creche.
Okay, so that's an example, not too complicated. Another young man who is currently in ADHD treatment, who will be transitioning at some point. He's 17 and a half. When do we start? When do we start thinking about his transition? He's not in a place currently where we could really consider that. He was referred to our service through the youth offending service because of his violent assaults in the community. He was out of school at 16, in a lot of difficulties. He was using substances, cannabis and alcohol at times, but preferring cannabis because it calmed him down and helped him to sleep. He had ADHD treatment for about a year when he was 10, but he didn't make the transition to secondary school. And he wasn't able to continue at that time on his medication for ADHD, so he dropped out of treatment then, and as he dropped out of school. And he didn't have family backup that kept him in treatment or kept him in school. So he comes to a service like ours where we scoop him up and we work on an assertive outreach basis, and we get him on medication for ADHD, and we work around his complex situation, which was with his girlfriend who's had a baby, and there was an enormous journey over the last year of that family situation going through court and childcare proceedings, and his baby has been removed into the care of another relative, but he has maintained his engagement with our service. And he came back last week to tell me how cross he was at the report that I'd written in June about his mental health and his non-compliance with his ADHD medication. But he came back to our service reluctantly and was able to say that, and he's still involved with our service. So how on earth are we going to transition him into adult services? I think it's going to be quite tough because he's not going to meet the criteria, and he's not someone who's yet ready to, he won't go out to a clinic appointment at the moment. We're trying to get him into training and education, trying to get more stability around him so that we can create more of a structure that would actually get him into adult services. So here's an idea. This is a young person, young adult, 20 years old, who was referred to our fledgling social enterprise company, Families Inc. We, as child and adolescent psychiatrists, had on our website thought of a number of areas of work that we could potentially offer. So this young man had found out through the website, and we're listed on a Department of Health listing of services in the Southwest, about our service. And he, with his constellation of difficulties, he's at Southampton Solent University, in the middle of a degree, and he has a history of prison. It was in prison for a year that he got his qualifications to get him into university. He's on methadone. He is opiate dependent, and he's in treatment with the local service in Southampton. He did have ADHD diagnosed and treated between the ages of 10 and 13, and he stayed in school, but things began to fall apart for him in adolescence as his ADHD kind of wasn't recognised. He dropped out of treatment, school began to fall apart, and he got good GCSEs, but then couldn't hold it all together in sixth form. And that's when he was convicted of possession of heroin, and he was sentenced to prison in Cardiff. I think he was in prison there. And he didn't get any treatment there, but he was put on a methadone program there. So he had approached other services, other adult services, for assessment for ADHD, and they wouldn't accept him at all with that profile. So in your adult clinics, would you consider a treatment trial for ADHD for a young man like this? Could you have a quick show of hands as to how many people would give a treatment trial? Okay, right, that's really encouraging. So, okay, and it's good. There are people here sort of saying, well, of course, you know, so that's great. Okay. That wasn't the response that he got when he went to local services in Southampton. So with our service, we saw him. He got the train up to Warminster. We're using clinic rooms in a GP practice there. So he came to a session there, was incredibly anxious, and we talked about his substance misuse and his treatment. And he did admit that he was using on top. And so we made a sort of contract and worked out that there would need to be a good communication between myself and his GP and the substance misuse treatment service, and he would need to come with 2 weeks of clean urine tests before he could start on a treatment trial with stimulant medication. And he was able to manage that over a Christmas holiday when he was staying with his parents. So they were in the loop as to what the treatment program was. And this was the first time since he'd been in a methadone treatment program that he'd ever been clean, that he'd not used on top of his methadone. So he came back to the clinic, and it was sort of with trepidation, and then with some growing confidence that he could have a trial of ADHD medication. And it was helpful to help him to pull together his college work. He had more focused support through the college support service, the psychological service. And he then he lapsed, and we talked openly at each session about his lifestyle and his substance misuse, and so we agreed that because he'd started using on top again, he would come off medication. But that was after a period where he'd had 6 months of being on medication, getting coursework done on time, meeting assignments, and getting through his second year of his university career. And he's now, over the summer period, he made a decision to go into residential rehab to really get free of the methadone treatment. And so with that motivation, he wants to restart ADHD medication. So working with these young people, developing services is enormously complicated. And at the moment, I don't think the current NHS structures allow for the development of these sorts of services very easily. So a huge range of issues. some of I brought 3 books with me today by Patricia Quinn. She writes really well for people who have ADHD, and she's got a great book called ADD and the College Student, which even my 18-year-old stepson has picked up and had a look at. This is all sorts of really helpful advice about how to manage your life when you move to university. In a really depressing climate at the moment, I think, we do feel that as psychiatrists interested in ADHD and interested in the mental health of young adults and young people, we really want to promote the development of services and support that help people to develop more positive social relationships. We are social animals, and the symptoms of ADHD have an enormous impact on our relationships. When they've surveyed children who are in school in treatment with ADHD about their treatment and about having ADHD and about what kind of stuff they want to be better in their life as a child with ADHD, what do you think the children say? What?
I want to be a better child to my family.
They don't. Okay. Any other ideas?
Get on with peers.
Get on with peers, yeah. They want to have friends, they want to go to parties. Their peer group friendships, our relationships in life as social animals are the most important thing. The other thing that happened to the 20-year-old university student was he met a girlfriend, and he's in a relationship with his girlfriend for the longest period of time that he's ever had a girlfriend. And she is an organising, stabilising influence on him, and as well as improving his self-esteem and his confidence and helping him to structure his life. It has an enormous impact, good social relationships. And I think being aware and being open about emotional regulation and the problems that it causes when it's unregulated. People with ADHD can get into enormous problems in work and in applying for jobs and going for interviews because they say the wrong thing, they're not confident, they get anxious, and then they react to things, and they find it hard to sort of wait their turn and then say the right thing when they're asked to do that, or do the right thing in a group interview situation for jobs. And family connections and services, I think, are enormously important. Sandra Coy, written K-O-O-I-J, a psychiatrist in the Netherlands, has created some really interesting lifespan clinics for ADHD, where families, including grandparents, parents, children, can access these clinics. There are groups for parents who have ADHD to look at how that impacts on how you are a parent and how you manage family life. Creches and time for children to be apart so that parents can get on with things, and also children can be helped with those peer group and relationships with other children. So, these are some of the potential creative solutions to future services. So it's all thinking in circles and not in lines. Okay? This is the kind of way that our substance misuse service in Bristol works. And it's complex, but we do hold things together, but we hold multiple aspects of a complicated young person's life together, which will include interventions that might be medical around their ADHD or their substance misuse treatment. But very significantly, it will include interventions to work with family communication, to address issues, to use individual approaches to psychosocial interventions, CBT, motivational interviewing, group work to look at how young people can help to practice pro-social behaviour in a group, do the right thing, say the right thing, be a bit more aware of their own behaviour, be more aware of reading the signs of other people's behaviour. So we're kind of, we balance our approach, we feel, with as much balance as we can, that's inclusive of all aspects of treatment, including medication where that's helpful. But I think, if anything, we sway our services towards the social relationships, the social context, the reality of the functioning of that individual in society. And that's where their transition as an adolescent is only going to work if they're really functioning in their social group and in their social context. Okay. So I'll finish there.